Good afternoon, everybody. I'm delighted to welcome you to Bloomberg Nursing's feature event celebrating National Nursing Week 2022. Before we begin, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. As part of our National Nursing Week celebrations, we at Bloomberg Nursing are grateful for an opportunity to recognise the impact of our global nursing community and the continued complexity of the nursing role as we navigate the changing dynamics of the pandemic. Before I introduce our keynote speaker, I want to remind you that this event is being recorded and will be made available on the Bloomberg Nursing YouTube channel. We'll send you an email after the event, which will include the link to the recording, as well as a survey opportunity for you to provide feedback that can help to shape our future event planning. The chat function has been disabled for the event, and your cameras have been turned off and microphones have been muted, but they will be made accessible to you again following the panel discussion so that you can participate in our Q&A. Our theme for this year, Revitalising the Global Nursing Workforce, connects and builds on the International Council of Nurses focus, which is invest in nursing and secure rights to global health. Our theme recognises the impact of the pandemic on the nursing work environment and the growing crisis facing the nursing profession around the world. This renewed focus on a long-standing and pre-pandemic issue also serves to inspire nursing leaders, policymakers and governments to seek innovative solutions in our efforts to shape the future of nursing. And now is the time for that leadership. It is my great pleasure to introduce our keynote speaker, Professor James Buchan, an internationally renowned researcher in labour economics and nursing workforce policy. Professor Buchan has authored recent evidence-based reports on the global nursing crisis for the ICN and is an adjunct professor at the WHO Collaborating Centre for Nursing, University of Technology, Sydney, and visiting professor at the School of Nursing, University of Edinburgh. He is also senior fellow at the Health Foundation, London. Professor Buchan's background includes periods working in government in Scotland and Australia and for the Royal College of Nursing in the UK. He's also worked for the WHO in Geneva and Copenhagen. In recent years, he has worked extensively as a consultant on nursing workforce policy and planning in Europe, the Americas, Asia, and the Pacific for governments and for international agencies. He is editor-in-chief of Human Resources for Health, the peer-reviewed journal affiliated with WHO. Following Professor Buchan's discussion, we will also hear from our guest panelists, Donna Duncan from the Ontario Long-Term Care Association and Taggar of Sunnybrook Health Sciences Centre, who will provide some local and provincial perspectives on the issues facing nursing within our own health systems. Over to you, Jim.
Many thanks, Linda. And I think I'm safe in saying good afternoon to you in Toronto. It's just after midday. To really reinforce the issue of globalization, I'm speaking to you today from Dubai, where I'm working this week and also participating in a couple of International Nursing Day events here in the Gulf. Normally I spend my time between Scotland and Australia, but the pandemic, as with everyone else, has very much constrained my own mobility in the last 2.5 years. If you could move to the next slide, please. Just to give you a brief structure for my presentation, what I'm aiming to do in the next half hour or so is not talk about Canada, but talk about the rest of the world in terms of nursing workforce challenges, so that we can, when it comes to Q&A, look at your own situation, your own challenges, and perhaps appreciate that some of those are almost universal, all countries facing very similar issues, much of it driven by shortages of nurses, which existed pre-pandemic, but have been very much exacerbated by what's been happening in the last 2.5 years. So I will the first couple of bullet points there, I'll spend a little bit of time just summarizing some of the pre-pandemic issues and the pandemic impact itself, but focus more on how nurses are having to deal with the pandemic challenges and look beyond those. Touch on self-sufficiency and discuss international recruitment, which I think is one of the major and growing issues for many high-income countries, particularly, and conclude with just a couple of slides which really summarize the key recommendations that were made in the report, which I worked with others on to publish for the International Council of Nurses earlier this year. Next slide, please. So just in terms of setting out the global backdrop pre-pandemic, coincidentally, the first ever global analysis of the nursing workforce was published by the World Health Organization in early 2020. It was called State of the World's Nursing, and essentially it paints the pre-pandemic picture because the data it used was up to around about 2019. The report itself was published 1 month after the pandemic had been officially acknowledged by WHO. So it gives us a picture of a world that doesn't exist anymore in one level, but it does give us a backdrop against which to begin to check and track progress or negative impacts from this pre-pandemic picture. So just 2 or 3 of the key points. Prior to the pandemic, 2019, estimated 27.9 million nurses across the globe. The shortage, the gap between supply and demand, as estimated by WHO, was at that time in the region of 6 million nurses. And perhaps not surprisingly, nearly all of the shortages were most prominent and concentrated in low and lower middle income countries, which in turn really pointed to the regions of Africa and Asia being where the shortages were most prominent. Next slide, please. An issue that I know Canada is facing, one that other high-income countries in Western Europe and other areas are also facing, aging nursing workforce and the implications that has for retirement increasing and what to do about what happens next. So about 1 in 6 of the world's nurses is expected to retire in the next 10 years, which really gives an additional replacement challenge of almost 5 million just to replace those who go. And when we look at the supply chain, how many new nurses are coming into the labor markets in different countries, very significant variation. I'll illustrate this in more detail later, but just looking at the difference between high-income countries and low-income countries, on average, high-income countries are graduating about 3 times as many new nurses as low-income countries, around about 38.7 graduate nurses per 100,000 population. And just to begin to flag the international dimension, about 1 in 8 nurses is practicing in a country other than the one where they were born or trained. And the data here is showing that after some initial hiccups during pandemic early phase, we are seeing back to significant growth in international flows of nurses. Next slide, please. So just going to look, as I said, in a little bit more detail at the actual impacts of COVID-19 on the global nursing workforce. Much of this will be familiar to you, but it's important to recognize that some of the challenges are very pronounced in low-income countries. Many countries' health systems were fragile before the pandemic. Many healthcare systems had significant nursing shortages. And we've then seen this impact, which has permeated and exposed any pre-existing problems. So we're seeing, obviously, infection up, mortality rates up, various types of mental health problems emerging, acknowledging those are not fully clear yet, risks in moral injury, stress, burnout, In some countries, there's been abuse and attacks on nurses. And in terms of the indicators of labour market shortages, beginning to see more of this emerging, driven by an increase in demand, which reflects growing healthcare demand because of COVID itself, but also increasing numbers of nurses leaving or intending to leave the workforce. Next slide, please. I'm not going to dwell on these slides in any detail, but just really to summarize what countries did during the first phases, the surge phases of the pandemic. As you scroll through, I'm sure most, if not all of these, will be familiar, but most countries tried most of these, and with very varying degrees of success. And particularly, I think, varying indicators of mid to long-term success. And much of this is related to the temporary nature of some of the interventions, requiring student nurses to go to the front line, for example, attracting back returners or retired nurses to come back to work, keeping on nurses who maybe would have been leaving but stepped forward and have worked for a year or two as the pandemic has impacted. And also looking at tapping into international flows. In many cases, international nurses already in the country, but not yet practicing. So happening in most countries, varying degrees of success. And much of this reflecting the immediacy of response, the urgency of response to the initial surge phases. Next slide, please. And there's then this longer term challenge, which relates to a recognition that we have to work with COVID, and it will be with us, we think, for some time. But we're also trying to either return to more normality or move into a new normality, which is about running COVID response, but trying to build back up the healthcare system responses for delayed care in many cases, which has occurred because of surge. So many countries now looking at nurses very much front and center delivering vaccine programs. Not such a big issue or new example in countries like Canada or the UK, but we have seen countries where before the pandemic, nurses were not allowed to do any vaccinations. There's been fast tracking to allow them to do that. Flexible deployment, moving nurses where they're most required, brings with it all sorts of challenges in relation to managing hours, managing stress. This point I've mentioned already about seeing the reduction or end of use of short-term and voluntary nurses, and either that or looking to integrate them into the permanent workforce. The data I've seen, which is very fragmented, suggests that there is a relatively small proportion who will now come into permanent work, but most will step back. They've come forward for a reason, they're going to step back. Student nurses going back to finish their education, and a range of other issues there, which are being identified as specific enablers, such as retraining or additional training of some nurses to work in new areas. A lot of discussion around the scope of various types of digital technology support, which has been rapidly accelerated during COVID for some types of communications in particular. And also looking at the areas, so we're not just talking about numerical shortages, where are the skill shortages within nursing, and some of the key ones I've listed there. Next slide, please. So in summary, most countries have seen 2 or 3 waves with new variants coming in. So the surge hasn't been a one-off, it's been repeated across a period of more than 2 years now, made huge demands on many nurses in terms of heavy workload and long continuous heavy workload. We've seen a shift, as I've illustrated, from surge to sustain. This shift has not always been well managed, and there is a lot of work still to be done. And in many systems, there has been, in my view, overemphasis on individual nurses being resilient rather than system enabling support there to ensure that they can continue to practice with safe staffing and fair workloads. And as I've said before, but really reinforce what the pandemic has done is expose the limitations that existed before the pandemic in terms of shortages, poor geographic distribution of nurses, and to some degree, the wrong type of skills in some parts. Next slide, please. So one of the things I did for ICN was do a scan of emerging data and evidence on impact on nurses. And I was astonished and shocked by the available evidence. There was so much of it coming through so quickly. The limitation is whilst it's rapid, it's not comparable. It's different surveys using different methods, looking at different ways of assessing impact. But the cumulative effect when you look through the many surveys that have been published is quite astonishing in terms of just the level of concern that it raises. Again, I won't read those through in detail, but just a handful of survey evidence there, all really pointing to stress, burnout, post-traumatic stress disorder in some cases, high reports of burnout and work overload, and varying but increased reporting of intention to leave. And those are nurses who may be young, earlier mid-career, not ones nearing retirement, also considering leaving because of continuous high workload. Next slide, please. And as we look at burnout and beyond it and the impact on systems, I think there are several critical issues that need to be kept in mind. And I'm sure that during the Q&A and the panel responses, we'll cover some of these. So shortages have been exacerbated. There's very strong evidence, much of it pre-pandemic, that nurse burnout is linked to poor quality of care, lower patient satisfaction, and reduced productivity. So you, as a system, you cannot expect burnt out nurses to continue to deliver high-level care and maintain productivity. It's just not achievable in the long term. The pandemic has increased burnout, and what we are seeing is high increased levels of absenteeism, increased leaving, some nurses wanting to step down in terms of hours or area of work, and others looking to retire early. And those who remain, increasing levels of stress. And one of the big concerns is the surveys that I've seen so far, most of them don't get beyond intention to leave. It's too early to track leaving rates, but the high levels of intention to leave are very concerning. And one final point, great uncertainty around what does long COVID mean, both in terms of demand. It appears to be mainly going to increase demand in some chronic care, for example, but also the impact of long COVID on nurses themselves. A bit of an unknown at the moment. Next slide, please. So just to put some very rough and ready figures on what I've been talking about. With a pre-pandemic nursing workforce of almost 30 million and a shortage of around about 6 million, it just needs a 1% increase in those in the workforce to leave to add another 280,000 nurses to the loss side of the balance. A 4% increase in leaving rates, which I think is eminently likely, would mean 1 million fewer nurses across the world. So when we look at the global impact, the percentage may be small, but the numbers will be very high. Next slide, please. The report that we worked on with ICN, we didn't want to just stop at outlining the problem. That doesn't get us very far. So we looked at the evidence also on what we can do, particularly around nurse retention as a critical intervention. The more we can maintain and invest in the current workforce, the less will be the outflow and the lower will be the replacement challenge. And there is good evidence from many countries now about factors that affect nurse retention. I've got two different columns there. The first is the kind of pre-existing factors, those that were identified, well reported before the pandemic, and others which are much more pandemic related, the right-hand column. And some of those don't apply to Canada. You have good access to full vaccines, but there are countries in Africa where nurses are lucky if they've had one vaccination so far, and many have not had access to effective protective equipment. So there are huge variations across the globe in terms of the extent to which there is good access to support for health and well-being. So my argument here would be that we know what works in terms of improving nurse retention. It's just that very few health systems manage to get the right policy interventions bundled together and maintained and resourced and financed over a long enough period to have a sustained effect. I think that's where the focus has to be, a sustained policy intervention, not short-term one-offs. Next slide, please. I said I was going to touch on the issue of international recruitment, which is beginning to scale up quite rapidly. Just some data, pre-pandemic measures. England had round about 40,000 registered nurse vacancies. That's working in the National Health Service. So those are funded posts that they could not fill. Germany is talking about 150,000 new nurses being needed by 2025. Switzerland, shortfall of 65,000 by 2030. And one of the studies in the US suggesting that there will be around about 194,000 nurse vacancies each year. These are demand side indicators which pre-existed pandemic, but have grown in number since with new estimates. Next slide, please. And that means many countries are now looking to international recruitment to fill the demand supply gap. Some of the big countries around the world in terms of numbers of international nurses, US, UK, Germany, Australia. But we are seeing growth in other countries such as your own in France and Switzerland. And we're also seeing a broadening of the recruitment targeting. Pre-pandemic, India and the Philippines were by far and away the largest countries that were recruited from. That still is the case, but we're seeing a broad range of other countries come into the crosshairs now for international recruitment. Nigeria, for example, is now being actively recruited by the UK. There'll probably be somewhere like 2,000 nurses from Nigeria this year. And other countries which are less familiar, perhaps, are now being examined as potential sources. Next slide, please. I mentioned this point about the pandemic briefly intervening, but not in any way stopping growth in international recruitment. This is data from the United Kingdom where I have access to the national registration process, which allows us to track the number of international nurses registered every year. And what I've shown here is the 6th monthly figure of new nurses being registered since March 2017. You can see it was beginning to scale up, and then there was a brief 6-month crash, April to September 2020, which was when the pandemic essentially meant people couldn't travel. But we're now back up to pre-pandemic levels and now going beyond them. And my estimate is that this year will be a record since we have data in terms of the number of international nurses coming into the UK, driven by domestic shortages, driven by increased demand because of the pandemic. Next slide, please. So as I mentioned, India and the Philippines continue to be major sources, and with their particular approach to educating for export, training paid for by the nurses themselves. That will continue, but we are seeing outward migration from a range of other countries, which in some cases have not traditionally been resourced so much. Next slide, please. One example, just looking at India, and this graph really shows the response to international opportunities. It's the number of colleges in India that were training bachelor level nurses. Those are the ones who are attract and want to work abroad. And we've seen the number of colleges grow from a very small number 20 years ago to more than 2,000 now. 95% of those are private sector colleges. The nurses pay for their training with the expectation that when they qualify, they will move abroad. Next slide, please. So the flip side of reliance on international recruitment. I mentioned earlier about nurse graduations per population. This graph here shows OECD countries, the nurse graduations per 100,000 population. You scroll along there, you can see even in countries that are clustered together as high income OECD members, Australia has about 4 times the number of graduates as the countries at the other end of the scale, or in some cases 5. The UK, where I spend most of my time, around about 30, so a third of the level of Australia. Huge variation. And the lower your graduate output, the more the likelihood is you will have to look at alternative sources to fill the supply-demand gap. Next slide, please. So thanks for your attention. This is my final slide. Essentially, it summarizes some of the key recommendations we made in the report, targeted at 2 levels. The left-hand column was national stakeholders, particularly member state governments. The right-hand column was more focused on international agencies such as WHO, World Bank, ILO, etc. So if we look at the left-hand column, which is really targeted at country level or province or state level, we were putting a very strong argument that without safe staffing levels, nothing else will have a sustained positive impact. If you don't have safe staffing, you can try lots of other things, but the lack of safe staffing will undermine the impact. So safe staffing levels, we think, is a critical prerequisite. For many countries, getting their nursing workforce vaccinated is also a biggie. We're advocating strongly to do workforce impact assessments, to do a proper assessment of just what impact the pandemic has had on your workforce. And this can be local, this can be province, this could be national. What proportion are likely to stay with you? What can be done to encourage more to stay? What needs to be in place to support them? Reviewing domestic nurse education in countries that appear to be graduating relatively low numbers. Are they increasing the risk that they have problems by not graduating enough nurses? And are the curriculum in place as well aligned as they can be with current and future demands and changing population health requirements, for example, with long COVID? Looking at retention factors around pay, rewards, decent work, etc. And looking to enable the nursing contribution to be optimized. That is targeted mainly at countries where the opportunities in careers, career development, advanced practice roles are not yet in place. And the pandemic has created a situation which will drive this in countries and must drive it. And finally, monitoring self-sufficiency. The pandemic has exposed, for some countries, over-reliance on international recruitment can create difficulties in the short term. And in the longer term, it creates a situation where you're not investing in your own workforce, you're over-reliant on international recruitment, and you may be doing harm to low-income countries if your active recruitment is too high. So those are a bundle of issues that we are advocating that any organization employing nurses should consider: national, provincial, local. On the right-hand column, there are a few additional recommendations, which, as I said, are for international agencies. I won't dwell on those so much because I think the focus for the Q&A and panel debate will be looking at Canada within the broader context, but you can read those through at your leisure now or later. I'd really like to thank you for your attention so far. We had recorded my presentation in case the communications went AWOL, but I'm now tempting fate by saying it all seems to be going really well. So I'll just scroll on to the next two slides. The first one gives you the reference, although the link is in blue, so it doesn't come up too well. And the final one, the next slide, just shows you the report, which is available free for downloading if you're interested. Thank you much for your attention, and I'll hand back to the chair. Thank you.
Thanks very much, Jim, for that really thought-provoking discussion. I was struck by the strategies that you outlined that had been originally intended to address the initial phases of the pandemic and the surge, and were temporary in nature, but now, at least from my perspective, it seems that some governments at least are considering those strategies as more permanent strategies. For example, the internationally educated nurses and fast-tracking them, and using students in unregulated healthcare worker roles in extender programs, etc. I'd like to now introduce our panelists and invite them to share their perspectives. And it's my pleasure to introduce Donna Duncan, CEO of the Ontario Long-Term Care Association. Donna is an experienced public sector board member and executive with extensive experience in healthcare and academics. Prior to her current role as CEO of the largest organisation representing long-term care providers in Canada, Donna served as the interim chief executive officer of the Ontario Caregivers Organisation, where she led the organisation's startup operations, building a foundation for new leadership, and a provincial board to lead the development of services and supports for Ontario's family caregivers. Our other panellist is Rue Taggar, Executive Vice President and Chief Nursing and Health Professions Executive at Sunnybrook Health Sciences Centre. She's a registered nurse with her master's degree in nursing and holds an adjunct clinical appointment at Bloomberg Nursing, University of Toronto. Rue provides professional practice leadership to nurses and other health professionals, as well as executive leadership to the hospital's Tory Trauma, Dan Women and Babies, and Schulich Heart and Holland Bone and Joint programs. Welcome both Donna and Rue. And let me give you a little way to kick off here with the first question. We've just heard from Jim about some of the challenges our healthcare systems and profession are facing globally as a result of the pandemic, and in fact, pre-pandemic, and as an aging workforce. And how do you think these challenges that have been outlined align with the current Ontario context?
Why don't I go first? One of the other hats I wear is I do sit on the board of the Global Aging Network, and I would say there's shocking and remarkable consistency with what we're facing here in Canada and Ontario relative to other parts of the world. Prior to the pandemic, made a presentation to the standing committee at Queen's Park and said that we're facing a perfect storm, especially with regard to our health human resources and most particularly nurses. We know that our long-term care sector, our aging population is largely supported by nurses. We are a sector of nursing leaders, and I think the reliance that we place on our nurses really came to the fore over the last 2 years, and the pandemic shone a light on just how hard our nurses work, the scale and scope of of the work they're doing, the complexity of care that they're providing, and really doing so in many times in isolation of other parts of the healthcare system. So this is a pivotal moment. It's a discussion that we're having not only here, but we are having those discussions with our global partners and our national partners.
Thanks, Donna. Rue, thoughts?
Yeah, I mean, I would say absolutely the comments that were made in the presentation do align with what's happening here in Ontario, and I'll just sort of point out the ones that particularly resonated with me. So the first point being that our healthcare system was fragile prior to the pandemic. I mean, that certainly resonated. And in particular, I would state that certain specialized areas of practice in hospitals, such as the emergency department, intensive care units, were challenged much way before the pandemic really happened. I also will echo what Donna said related to our aging workforce and the expected attrition that has been mentioned. That's something that we knew before the pandemic, and it's just been exacerbated during the pandemic. And finally, the point around burnout and resilience. That's not a surprise for me to hear about that. I definitely feel that that's happening in Ontario and probably nationally. And as Jim said, it's happening globally. So it's certainly an area that we need to pay deeper attention to as we develop our strategies to address these challenges moving forward.
Thanks, Rue. You know, Jim referred to not only highlighting the challenges, but also providing some ideas around what potential solutions are. I wonder if Rue or Donna, you'd like to talk about what's currently being done across institutions and sectors to address those challenges that have been highlighted. And are there actually new opportunities for learning that will change how we move forward in our healthcare settings?
Yeah, absolutely. As we look at the lessons learned, we've really been spending a lot of time working in partnership with government and having discussions across the healthcare system around how are we going to build out a workforce? How do we share a workforce? One thing that we experienced in long-term care through the pandemic is when we were in outbreaks, nurses came to us from hospitals to help. But then when the hospitals were in outbreak, they left the long-term care. It's almost like a murmuration of swallows. We've got a fixed workforce that we need to be bold in retaining. The government of Ontario has brought in nursing retention payment for our nurses. In addition, we know that we need to be a little more creative around making sure that we are building out the workforce and building new nurses and growing new nurses. So we've been very fortunate. The government has stepped up with new preceptorships in our long-term care homes, supporting us with helping internationally educated nurses on a path to credentialing, as well as looking at what are the other things that nurses need. We know it's not all about money. It is about purpose. It's about support and well-being. It's about bringing in more mental health supports. It's valuing what we do, but also recognizing that as we think about the go forward, we need better data. We don't know what we're actually going to need in terms of net new, but look across the entire system and not nurses in long-term care versus nurses in home care, nurses in acute care. We need a more holistic view and also looking at where nurses and their scope of practice fit in with other health disciplines.
Thanks, Donna. Rue, thoughts?
Yeah, so I'll answer your question in two ways. So I'll talk about the three areas of transformation that I think is currently happening, which is great, and then where I see some additional opportunities. So I've noticed that there are three key areas that are becoming transformative, which in a positive way. One is as it relates to partnerships. So more so now than ever, I am noticing that healthcare organizations are partnering with other organizations to help address the issue in terms of workforce challenges. I'll give you some examples. So partnering with organizations such as CARE to assist with IEN recruitment, partnering with educational institutions like the University of Toronto more so, and other academic institutions to expand our ability to support the learner experience and ultimately increase the pipeline of new nurses with greater partnerships with educational institutions. And then finally, partnering with government and agencies to work more closely in a collaborative way to develop programs and policies to support the retention and integration of new nurses. So I think that's already happening. I'm seeing evidence of that happening within the system locally in Ontario already. We need to continue to see more of that happening. And so I think the theme of partnerships is really important. So where do I see some opportunities, new opportunities? I definitely feel we need a provincial HHR plan, a plan that is coordinated amongst all of us. We're all sort of doing the same kind of thing locally within our respective institutions, whether it be within the long-term care sector or in hospitals. And I'd love for us to be a little bit more coordinated with a provincial lens related to what we're doing, so we're not competing with each other for the same resource base. Also, the plan needs to have a vision, a very clear vision, which is more of a longer term vision. Back to what Jim said, like quite often what I'm seeing is strategies being put in place that are more immediate in nature, and we need to be thinking from a long-term, longitudinal perspective. And finally, I think, you know, as much as some of us may not want to accept this, new models of care are probably here to stay. And so we need to be able to evaluate the impact of new models of care, not crisis models of care, but actual models that optimize the scope of practice for nurses, models that actually enable other healthcare providers to help augment our teams in a meaningful way. So nurses can do nursing duties and take on nursing responsibilities, and the non-nursing responsibilities are augmented by providers that can do that. And then I would also say that mentorship and effective onboarding of new staff is going to be super important as we continue to move forward in terms of effectively integrating new nurses into practice. And finally, and probably the most important point, is institutionally, we need to ensure that whatever we are doing, we have a clear line of sight on the impact of quality, and patient safety in terms of any changes that we are making to practice related to the workforce. So always having a line of sight in that area is going to be really important.
Thanks, Rue and Donna, both really important points that you've provided there. And rather than me rabbit on and control the spotlight here, I'm going to open it up for Q&A now, actually, because I'm sure there are many people, and in fact, we've got 128 people here, which is lovely to have. So thank you all for attending, and let's open it up. You should be able to use the raise hand function and unmute yourself now if you have a question or a comment. Judy Linton, I see your hand shoot up there.
Thank you very much. Really appreciate the presentation. So I was going to ask the question about models of care, and Rue has already raised that. So we are tasked at Ontario Health with thinking about how we manage subsequent waves of the pandemic, and granted, this will go way beyond just pandemic, but I just wonder if Jim or others could comment a little bit more on models of care and how we might change models of care, refine models of care, and actually get nurses engaged in different models of care, because it has been very challenging over the pandemic because we had to do it so fast, and I think, to Rue's point, didn't really have the opportunity to think about the impact on quality and safety. So just wondered if we could delve into that a bit deeper.
Thanks, Judy. Who'd like to take that? Donna, Rue, Jim?
I'm happy to kick off. Again, from a more international perspective, I think it's a critical question, and I have been struck by the extent to which there is a sense, which other panelists have already raised, that some of which was done urgently and quickly in terms of change has the feeling of being around longer than might initially have been considered. But as yet, with very little evaluation of whether or not it's in the right direction or not. And some of it intuitively feels right. And I would point to fairly rapid developments in primary healthcare in some countries, where we're seeing a rapid recognition that there needs to be better integration of primary care, and that for any preparedness for future pandemics, that's got to be an area of a lot of effort. Particularly in countries where there is a fragmented system, a recognition of the need to move towards proper structure, and huge potential for nurses to be developed into higher level roles in primary care. One of the other things that just I'm reflecting on that I heard in terms of panelists, and this is more about the kind of overarching planning and policy framework. But if you don't have that in place, I think the risks are that some of the urgent responses don't get properly captured and assessed. And some of the good ones might dissipate, but some of the bad ones might stay on. And it's to look at, in your context, what you call would be a province level. And I think that's usually about the right population size to be doing this kind of workforce planning, workforce projections, workforce policy, and thinking that through. And I just cite the example of my own country, Scotland, which is a population of 5 million. So it's about the size of a province, although we would claim we're a country and we've been around a while. But we, about 2 months ago, published for the first time a full national integrated workforce strategy for health and social care across National Health Service, private sector, which is quite small in Scotland, and NGOs and third sector. And the aim there is to try and pick up on what Rue was saying, which is give us the backdrop to look at new models of care, which might not just be within the constraints of current organizational structures, but might have to read across in new ways. And that cannot be achieved just by a restructure. That's just moving the deck chairs around the Titanic. It's looking at the capacity, for example, for workforce to work in different ways, or new roles to be introduced, and for breaking down some of the employment contract barriers that might exist. Then you get into issues of different terms and conditions, and that has to be fixed. But the risk is some of that stops this happening. I think we've got to look at enablers there, so that the new models of care that come through can be rapidly rolled out where they have promise, and improved or stopped if they don't.
And Linda, if I could just add,
Sure.
It's Donna. One thing that we're really seized with in the long-term care sector is how do we deconstruct our care models in a way that are built around the people we care for? Who are we caring for and where? And as we look at the census data that came out in Canada last week, the population over 80 is going to double in Ontario over the next 10 years. How do we support frail seniors? We need to look at all of the pieces of the puzzle and how are we going to meet people's needs where they live? We all want to age in place, but recognizing that we need to reimagine what is long-term care, who are we caring for, and how are we going to care for them, so that it's a much more holistic approach to looking at integrated models of care along that continuum. And we're building those services around the people who need them, not around architecture of an historic system, to Jim's point.
Thanks, Donna. Rue, thoughts?
Yeah, I mean, I'll just sort of reiterate a couple of things, appreciating I see Karima's got her hand up. So again, I want to make the distinction between the models of care that we implemented during the pandemic, which was quite frankly, in my mind, crisis staffing. And really, I think we do need to make a separation between crisis staffing models of care. That's not what we're talking about in terms of looking at new models of care and how we can purposefully evaluate them and configure our teams in a way in which we are optimizing roles as much as possible in a complementary way. So I do want to emphasize that point, because quite often we get caught in, when we're thinking about models of care, we're thinking about what we implemented during the pandemic. So the other thing is, I will just sort of reiterate that I think institutionally we need to think about safety thresholds. So Jim made a point about that in terms of his recommendations around whatever we do, we need to think about what is an appropriate level of safe staffing, regardless of how we configure our teams. And so we definitely need to, in terms of moving forward, we definitely need to have a line of sight around what our safety thresholds are moving forward. I'll stop there, Linda.
Thanks, Ruth. Appreciate that. Karima, thanks for joining us.
Thank you. I agree with so many of your comments, but I think a fundamental rethink is needed for nursing. And I think we have to put a mirror to ourselves. With the numbers you've just cited, Jim, there is no way. With the number of people graduating and the gap that faces us in the next 10 years, there is no way, if we continue practicing in the same way, in the same places, with the growing demands for healthcare, are we going to meet the needs of the populations that need us? So more and more, I feel a mirror needs to be put to ourselves as a profession, and we have to reimagine nursing for the future and make some tough decisions. There are places where we can take our rightful role, a rightful place, and make a difference to the populations that we serve. The elders come to mind, mental health and addictions comes to mind, like vulnerable populations where nursing is best suited to create the status, the health status for the population. And in so doing, I think we have to be ready to give up some of the current spaces that we are in, particularly if the current practice is such that majority of our day is following a set of orders that someone else writes and we follow it, and a technician can do that job, frankly. Like, it's time to give up on some things and take our rightful place in the system. Only then can we align to the patient population needs. It's just the numbers don't add up for me. And are we prepared to do that? Nurse-led practices, nurses as most responsible practitioners, I mean, the populations I've cited are well suited. That's the growth opportunity from a population perspective. But it is dying for nursing to take its rightful place and make a difference there. You know, I often cite when I'm speaking the Blue Ocean Strategy for nursing. If you haven't read the book Blue Ocean Strategy, you must, all of you. It's time to give up the places where we are competing for scope of practice, the red oceans we are trying to compete in, and take the very rightful place. Jim, you mentioned primary care is our thing. It's the thing of nursing. Are we placed in the right way? Have we placed ourselves ready to take on that opportunity to play in the primary care space? That is our space as nurses. Our curriculum preparing us to graduate and take our rightful place in the future healthcare system. I mean, there's so much to think about from all perspectives: school, the preparation of nurses, the regulation of nurses. But fundamentally, I think let's stare at ourselves in the mirror and make the changes we need to make. Because others will step up. I see it. I see ambulance workers, first responders stepping up and occupying spaces where nurses should be placing themselves and taking hold of those populations and shining. But we are busy. We are very busy in med-surg settings, following tasks, following orders of physicians. It's time to put a mirror to ourselves. Sorry.
Thanks, Karima. Anybody on the panel want to respond to Karima's comments? I just want to follow up on one of the comments in the chat, actually. about thoughts on the growing use of temp agencies and apps in the provision of nursing staff, and nurses burning out and seeking to get more control over their hours of pay and increase their pay for that matter, while the agency itself is obviously gaining some income, so that we're actually paying more for less. I don't know if anybody wants to comment in relation to that shift.
In our long-term care system, this is perhaps I would say the #1 issue that our homes are talking about. We have communities across Ontario that have no nurses, and they are turning and relying on the agencies for their support. And this is where we're seeing a lot of movement, where people are retiring and moving to work for agencies and looking for some of those things that Jim highlighted in terms of flexibility, being able to choose shifts when and where they want them, wanting to choose the environment within which they're working, whether that's a hospital, acute care, or long-term care, or home care. So that mobility element, and then also getting more money. And so we know compensation isn't the only thing, but this is a worrisome trend, especially in a very highly regulated sector like long-term care, where 24/7 nursing is prescribed, and we're working under emergency orders still, and we don't quite know how we're going to manage as a sector once the emergency orders or the pandemic is over, and how will we manage without nurses when in so many communities the only source of nursing is agencies. It's a cultural shift that we have to find a way to manage.
Thanks, Donna. Rue, thoughts?
Yeah, I mean, I would sort of reiterate what Donna said in terms of, well, what can we learn from this? I'm not surprised that this concerning trend is happening. Agencies are businesses and they are being opportunistic. And when you're running a business, that's sort of how it goes. That's the way, that's our system. I guess the underlying question for us, which is what Donna actually answered, was, well, why are people moving more towards agencies and not their workplaces and staying in their regular places of employment? And is it because of flexibility? Is it because, you know, we need to challenge ourselves in terms of how can we create more of an attractive workplace for our workers, and a more of a, you know, to enhance wellness and sort of health of our workers as one aspect of it, and to address retention that way. So I think it's causing us to reflect as employers what else we can do to help retain our staff, which is obviously an important component of what we need to be doing with a long-term strategy.
Thanks, Rue. Jim, I can see you nodding.
Yeah. I just to pick up on that, I think essentially what I see happening is that what we need to try and support is more building in a flexibility rather than buying in. And the impact of the pandemic, certainly in the countries I'm aware of where agencies are part of the landscape, has seen agencies growing in terms of provision in certain parts of the system, but declining in other parts, depending on how the pandemic impacted. And we've been trying in the UK to put various fiscal controls on the use of agencies in terms of certain types of contract, or limiting spend, or requiring NHS institutions to go through kind of fairly complicated protocol before they can commission it outside agency staff. Because, I mean, it is recognized that firstly, it's more expensive, and secondly, it does raise, and in some cases, compromise quality. If agency nurses are not familiar with the workplace they move into, there often is an impact, which is that the existing staff have to step up a bit more. So I think looking at extending the flexibilities on offer for your employed nurses makes sense anyway, but there is a kind of additional benefit if that reduces reliance on external temps as well.
Thanks, Jim. Whilst others are thinking about questions for the panel, I just want to take the perspective of the academic side of the house, many of whom are on this call too, and I think I'm speaking for colleagues when we think about we're being asked to expand our programs, increase the number of people in our programs, and yet we do have some concerns around those new grads and how they're going to be supported to transition into their post-licensure roles. Anecdotally, we hear, and this was pre-pandemic too, obviously, but it's more so now where people perhaps didn't get the clinical placement experience that they might have had otherwise, where people are not staying, they're going out into that workforce as new grads. There isn't the resources and supports available that might normally be there due to all the reasons we've talked about. And so it's kind of a loss, a loss-making exercise to continue to pump people into our programs when in fact they're not going to be staying at the rate that we would want them to. I don't know if people have got comments on that.
Linda, I'll make the comment just to say that I think there's more we need to be doing in terms of mentorship of new grads, effective onboarding, and creating career pathways for our new nurses that are entering the profession. And I think we've started on that journey. I think some government programs have enabled us to create mentors within our workplace settings, but that's subject to some funding that we have right now. We need sustained ability to have mentors available in our practice settings to help effectively integrate new nurses into practice, so they want to stay in nursing and they want to choose nursing as their career and they see it as a career. So one of the things that we've started to do at our hospital is to start developing career pathways. So once we recruit a new nurse, the first conversation we're going to have with them is, how do you see your future here at Sunnybrook in 5 years, 10 years from now? And have our leaders have the discussion with the new recruits around, how can we help you achieve that plan for you? So I think more of those kinds of conversations with new nurses, new grads, is going to be really important as we move forward.
Thanks, Rue. And Donna, do you have a perspective on getting new grads into your sector and then keeping them there?
Yeah, absolutely. And I'll echo Rue's comments around mentorship and support, helping students understand what the opportunities are in long-term care, the value of working in long-term care. We're a stigmatized sector, and the last 2 years have not helped us, not just in Ontario, Canada, but around the world. So we've spent a lot of time in working with government. We are celebrating the investments in preceptors in our long-term care homes. How do we ensure that our students are set up for success and that we're building in those nurse educator roles into our long-term care homes, as well as creating communities of practice? One of our challenges is that nurse leadership is key, and to Karima's point, we have a lot of checklists and a lot of administrative work. How do we support nurses in actually nursing and providing care rather than just administration, but also supporting them in managing risk and ensuring health and safety and well-being? So for us, the pathway is to build out more academic supports, more clinical supports, and also look at those partnerships with academic health sciences centers and faculties, so that there is a broader and a longer pathway that supports them within the context of the broader healthcare system. And we're seeing some of those new models with infection prevention and control, hospital hubs, some of the transitional programs that have been built out over the last 2 years. But again, to Rue's point, we need an integrated longer-term health human resources strategy that where our academic partners and the faculty of nursing and our schools are actually at the table and part of the solution, and understanding, what do our students in the pipeline today, what will they be looking for, and making sure that we're working towards that as well.
Thanks, Donna. Jim, Siobhan Nelson's posted a question for you, as you can see in the chat. Any comments on the faculty shortage, which is really a
in fact, I was halfway through typing response, so I speak quicker than I type, so I'll go back to the verbals. Hi, Sean, a really good question. Yeah, education capacity, and particularly lack of nurse educators, is a major drag anchor on expansion in some countries. And I can cite the UK as an example. We've had, as have some other countries, a marked increase in possible applicants to nurse education as a result of COVID, particularly the first year, where nursing had a very high profile, very positive profile. And the major limitation in our system on absorbing these applicants is the university system, which has very limited scope to handle any more student nurses. And this is partly to do with the nurse educator group, which is even older on average than the most clinical nursing areas. And often in countries is disconnected in a way that the career opportunities, once you go into academia for a period, don't allow you easily to move back in and out of service. So you're on a tram line, and this means you can't easily ramp up education capacity quickly. So it's going to be a major constraint on growth in some countries. So I agree strongly with Siobhan's point.
Thanks, Jim. And just some other comments I can see in the chat. Harris has posted a link to a discussion paper on the 12-hour shift. And Julie, thanks for your comments about treating nurses as dispensable for at least the last 30 years. And this question that comes up in quite a few forums around nurses are seeking full-time positions, but the perception, at least, is that they're not there. They want full-time work, and what's being offered is part-time. Particularly interested, Jim, if you've heard that in any of your discussions, and Rue, I know we've had some discussions around that in various forums together. I'm just wondering, as we start to draw this session to a close, if there's thoughts around that.
Perhaps I could kick off. I mean,
Sure.
There's significant variation in different countries. Coincidentally, I was speaking to someone earlier this week about the extent to which part-time opportunities need to be there as part of flexibility, but also can make the challenge of getting the numbers that obviously that much more pronounced. And the extent of part-time working varies hugely across different countries in nursing. Some countries it's enabled by legislation and custom and practice, and part-time working is well paid and career oriented. In others, it's regarded as second class, and it's a career dead end. And in some still, it's virtually impossible to work part-time. Right. So I think what we've got to be looking at there is part-time as part of the flexible offer, but part-time that connects in with longer term career opportunities and therefore retention.
Thanks, Jim. Rue, did you have anything in particular, or Donna, to add to that?
I mean, I'll just make 2 points. One is I think it's a balancing act. So to Jim's point, I think we have to find the right balance. And I don't know what the right ratio is full-time to part-time, but I think we need to sort of be mindful of it and understand the implications and try to find the right balance. The next point I will say, though, Linda, to the question, we don't have any data, so I don't know. And I think that's a larger point that I'd like to make, is really understanding what is the current situation and having a transparent situational awareness of what the current state is, whether it be full-time, part-time, what's the gap in terms of the demand, all of those, overarching matters, I think need to be quantified and transparently shared provincially. And I don't really have a clear line of sight on those matters.
Yeah. Thanks, Rue. I think to be respectful of everybody's time, we'll bring the session to a close. So I'd like to thank Jim, Donna, and Rue. I think I speak for everyone who's attended today in saying this was an incredibly engaging and important discussion about what's facing nursing today. And it's also somewhat comforting to hear about the possibilities for change and the ways that we can innovate to move the profession forward. As Nursing Week continues, I'd like to remind everyone about our remaining wellness-focused events. including a cardio dance party hosted in collaboration with U of T Sports and Rec, which I personally will not be going to, and a paint night with social art, which can be done virtually from the comfort of your own home. And links to these events will be included in the email following this event. We'll also invite you to visit our website for further details or check out our social media channels. Thank you again for attending our feature event for Nursing Week. Stay well and enjoy Nursing Week. All our very best wishes. Thanks, everybody.